morning, everyone. Welcome to the CAT Lab number 2 of the number 1 hospital of Harbin Medical University. And today is just the transmission for the routine case. There's no specific theme. So Dr. Zhao will introduce the case first. Dr. Zhao, please.
This patient is a 62-year-old male. The main risk factor is hypertension. His echocardiogram showed an ejection fraction of 68% with no motional abnormalities. The electrocardiogram showed sinus rhythm and no TV inverted, and ST segment depression. Coronary angiography showed that there was a severe stenosis in the proximal LCS, but the patient refused PCI. 2 years later, in another hospital, angiography revealed total occlusion of proximal LCS. Receiving both collateral from LAD and RCA via PLV branch, the patient underwent a field CTO PCI with an Anterograde approach, and then we have performed a CTA scan, and the results showed that the occlusion length is very long, more than 20 millimeters, with no calcification. In order to understand the coronary artery lesion deeply, the intelligent visualization system for CTA. Please, Professor Li Xiankai, introduce this part.
The 3D reconstruction image shows there are two occluded parts in the LCS. One is in the proximal and the other is distal part. Distal part is relatively long and without calcifications. That's all.
This is a very typical circumflex CTO. And from the CT angiography, we don't see severe calcification. So according to anatomy of this lesion, I think it's a GCT score 2 C2 lesion. So Dr. Gong, so we have enough information about this lesion. What's your strategy?
Both these steps will give me a lot of information. Firstly, from the CTA result, we can find the proximal cap located just the bifurcation from angiography. Carefully, we can see the tapered. Next, from the dual injection, we can see that RCA oriented from RCA several epicardium collaterals, but it's very small. And for this patient, the antegrade approach is our first choice. And the distal 2 lumen, of course, this is the good result. We will quickly finish the case. Otherwise, if the Y entered subintimal space, as we know the extra plaque, then we will perform the re-entry.
All right, so based on the anatomy of this lesion, because we can see a tapered proximal cap, and the condition of the contralateral is not that good, so the antegrade approach is preferred, right? As you mentioned, we could do the antegrade wearing technique. If the wear goes into subintimal, we can do the ADR, right?
Yes.
So, but before actually we did the avastron, right, in the OM to see the proximal cap of the circumflex. Can we show the audience the avastron?
Okay. For this patient, intravascular image is also important to help us to find the location of the proximal cap and to confirm the location. So we performed IVAS pullback from OM to find the and to confirm the location of the proximal cap as just we we understand the information. Okay, from this theory we can see this is OM lumen, and from distal to the proximal, they are very okay.
Here comes the
yes.
circumflex.
This is the proximal cap of occlusing segment. There are several significant stenosis at the proximal segment of OM.
So after the AVAS, I think we have a better understanding of the anatomy of the circumflex occlusion lesion. So because there's a taped cap, what kind of wear you choose to penetrate the proximal cap?
As we know, for the tapered proximal cap, usually we choose a softer tapered tape and with a polymer injected Y. For this case, we choose field XTY for the first choice.
So when you try to deliver the wear, it didn't feel much of the resistance, right? It's kind of easy.
When we encounter the resistant, next step, we exchanged the KDL, the dual lumen microcatheter, to the Cossier microcatheter to enter the occlusion segment to give the Y more support and enhance the penetration force of the Y.
So when you deliver the wear, you did feel a little bit resistance, and that's why you exchange the dual lumen catheter with the macrocatheter, the Corsair, right?
Yes.
To increase the backup. And then after the use of Corsair, I think the wear was kind of easily to be delivered to the distal part of circumflex.
And yes, the distal Y location is very important. This should be confirmed by the collateral injection or collateral angiography. After confirmation of the location of the distal Y, we found it located in the distal true lumen. Then we entered we advance the micro catheter to the distal segment and perform tip injection to confirm the true lumen again. In some cases, the Y entered the extraplex space or the intimal space, and then we will perform ADR technique, that is antegrade dissection and reaging technique. But fortunately, for this patient, performed Y advancing across the occlusion segment successfully to the distal true lumen. After prodilatation, next we will perform EVAS imaging and to the next PCI step, for example, the DB or DS.
So as a CTO operator, I think it's very important to switch strategy based on the situation. The lesion is kind of diffused, but I think the plaque is kind of fibrous. It's not a calcified plaque.
Yes.
But there's no good spot to land the stents.
Yes.
And then what's next?
I think DB may be a good choice. And next we will bring a dilation the lesion again with a cutting balloon.
So before the use of DEB, I think the pre-treatment is super important. We have to well pre-treat the lesion first, and then the DEB can be well expanded, and then the drug can be released into the vessel wall. 2.0 in the distal parts.
Yes, it's very small, but 2.0. But the location from the location to the proximal location is very large. 1, 2, 3, 4, about 3.5 millimeter. The diameter of the segment.
So how many DBs will be needed?
Maybe 2. Okay, let's give me a 2.5 cutting balloon.
So because the plaque is kind of fibrous, that's why you choose the cutting balloon to pre-treat the lesion, right?
Yes, very heavy plaque burden.
So in terms of the pre-treatment of this lesion, do you think there's a difference between the cutting balloon and scoring balloon? Is this scoring balloon is also okay for this lesion?
Yes, in fact, cutting balloon and the scoring balloon,
Mhm,
it's also
mhm,
have the same efficiency to pre-dilate
mhm.
the fibro plaque
Mhm.
lesion.
So either of these two tools will be fine for this lesion. It's just a personal preference. Dr. Zhao, when people deal with the CTO
Well,
lesion, when they try to use the integrate approach,
Mm.
so sometimes if the first wire goes into the subintimal, they
Mm.
may use the parallel wiring technique. So can you share with us about that technique?
Yeah. The parallel wiring is a very useful method in the CTO PCI, especially in the Anterograde CTO PCI. The parallel wiring technique allows the operation to keep the first wire, which has gone into the subintimal space into the distal cap as a marker where a second wire can modulate into the true lumen and guided by the position of the first wire. This technique have just three obvious advantage. The first is the user contrast to locate the position of the distal true lumen can be reduced due to relying on the position of the first wire. The second advantage of the parallel wiring technique is the first wire can act as a rail to guide the delivery of the second wire into the CTO body. The second advantage of the parallel wiring technique is the existence of the first wire reduced the risk of the higher penetration wire going outside the vessel through the CTO body by acting as an indicator of the vessel course. Thank you.
Yeah, I think the
Mm.
parallel wiring technique is one of the commonly used anti-grid techniques. So thank you so much for the sharing. I think that's very important for some beginners. So Dr. Gong, after the use of cutting balloon, you will use some NC balloon for further dilatation?
Yes, after NC balloon dilatation, we will perform intravascular imaging again
Mhm.
to help us deciding the next DB or DES. Both a good choice.
You haven't decided yet, right?
Yeah.
It could be DB or could be DS.
Dr. Gong, here is Jingyu. There are some questions from the audience online to you. The first of all, they want to know, are there any techniques or tools that help you to improve the effectiveness of anti-grid approach this time? I know Professor George just talked about it, but they want to know your opinion.
For this patient, the case is very suitable for the antegrade to recanalize the CTO's lesion because the epicardial collateral is very poor according to the size and the continuous. And the antegrade one, as we know, include several techniques, including the antegrade Y escalation and parallel wiring and ADR technique. Both can be used according to the first Y, the location of the first Y distal. From the angiography, we can see the team of the occlusion segment is successfully recanalized,
Mhm.
and there are no significant dissection. It's okay.
2.5 or 3.0?
2.5.
2.5.
Okay. Give me a little contrast. Oh no. Here, here, here. Okay. No, no, no. Left. Okay. It's about here. Okay.
And Professor Gong, another question from the audience online. When will you remove the guide wires from the RC and the LAD?
Contrast. Okay. That's
Yeah, I think, after the stent implantation,
little contrast.
the contralateral injection is not needed. And then
Okay.
the guide wire in the RC could be removed. When you will remove the guide wire in LAD. Yeah. Because right now the guide wire in LAD can stabilize the guiding catheter in the left corner system, and then it can give you more backup.
Well, and the guide wire will be removed after the finish the entire.
So just now we already see there should be some tight lesion maybe in the distal RCA. So I think we should check with IVAS first. There is severe stenosis if need to be treated first.
We are, switching to the retrograde approach. Since the anterograde, stingray balloon-based ADR techniques, it doesn't have a clear view of the distal reentry site due to the maybe potential antegrade hematoma, and also that we can see antegrade parallel techniques
A little bit.
doesn't make very good progress. And also, if we perform these ADR techniques in the relatively mid or distal part of our AD, we are taking the risk of losing relatively two or even more relatively big side branches. So now we are switching to the RCA. And first, we can see there is a relatively long diffused plaque distribution along the RCA. Yes, collateral flow from the distal
Yeah.
RCA. It seems that
By
the
septal wire surfing.
yes, it seems the contralateral flow from RCA is a combination of several very small collateral chambers that form the angiography from the retrograde. It's not, good enough, which means to reach the CC level 3 or even better collateral flows.
Yeah.
That's why we are trying the antegrade ADR techniques first, not the retrograde approach on this case. The far ending of the RCA is relatively long, but it doesn't seem to be connected with the septum collateral channel. So if the retrograde approach doesn't go very smooth, do we try to perform last from antegrade?
Yeah, I may try
Mhm.
like may use ADR technique again and may
Mhm.
try start technique.
Mhm.
And finally, if really doesn't work,
Mhm.
may try spam.
Spam, yes.
So that means if the wire in the
Mhm.
vessel architecture not come to distal to lumen, we could use balloon to dilate, test a little bit in the subintimal space.
Okay.
And sometimes when we redo angiogram about 1 to 3 years, are you please? Sometimes for some case may recanalize.
Right,
Yeah,
yes,
even
recanalized by
recanalize.
itself.
Yeah, but even couldn't recanalize may increase the next time success rate.
Yes.
Okay, test a little
The
bit.
previous manuscript indicated 70% of a successful recanalization after spam as a follow-up 2 to 3 months.
I don't think that's where this branch could be used. Really, no very good. Okay, should be this one.
It's hard to say where its exit point.
Yeah, maybe in the proximal portion. Okay, maybe some double channel, but more close to. Okay.
Yes, it's connected, yes, to the
AP cranial. I think
Yeah, yeah, yeah. I
Thank you.
think we are already in the right direction.
Mhm.